trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Vadisha Bhat to start this session. Welcome and over to you, sir.
Good evening. First of all, let me thank NBE for inviting me and involving me in this educational series. And today's topic is a common one. However, as sir already mentioned, there may be few questions which are not routinely discussed. And I hope this is a good opportunity for us to discuss and resolve any issues which are not clear to any one of us. So I am Dr. Vadisha Bhat, Professor and Head the Department of ENT, KS Hegde Medical Academy, also known as Kshema, affiliated to NITTE, deemed to be university in Mangalore. So to begin with, the classification of otitis media, as we all know that the otitis media is an infection of the mid-ear cleft. So it is classified as suppurative and non-suppurative and some miscellaneous or specific conditions. In suppurative, we have acute and chronic. They are their own separate entities, a lot to be discussed among them. In non-suppurative, we have, again, depending on the duration, we can classify them as acute and chronic. And miscellaneous are always specific. Example, tuberculosis and syphilitic otitis media. Now, the topic of today's discussion is the otitis media with effusion, which is known by different names. And the common name for the common people and even among the medical fraternity, that is the glue ear. This is because the collection in the mid-layer cavity is something like glue. In fact, that is the thick mucus that is collected in the mid-layer cleft. It is also called serous otitis media, considering that the fluid is serous at times, also called mucoid otitis media. So this shows that the content, that is the collection in the mid-layer cavity, is not always uniform. It may be a thin fluid when it is called, that is why it is called a serous otitis media, and it may be a thick secretion, that is why it is sometimes called a mucoid otitis media. It is also named by some as a catarrhal otitis media because the most common cause of this condition is common cold. It is also called exudative otitis media because the collection that is there in the mid-layer cavity is an exudate from the mucus glands that are there in the mid-layer cavity. Commonly, it is also called non-suppurative otitis media because it is the collection, the secretions in the mid-layer cavity is not pus. So it is not due to a suppurative infection in the mid-layer cavity. However, the otitis media with effusion or the middle ear effusion, the latest one that is mentioned is the middle ear effusion, which answers all the doubts what we have, is still why it is called otitis when it is not a actually a suppurative infection in the mid-layer cavity. So that is why many times it is simply called as mid-layer effusion, because the collection in the mid-layer cavity can occur even without any infection in the mid-layer cavity. So define otitis media with effusion, a clinical condition characterized by the presence of non-purulent, that is the sterile fluid in the mid-layer cleft. It is often missed. So we have few studies, even I was involved in 2 of such studies, where the otitis media with effusion is diagnosed as an incidental finding in children undergoing adenotonsillectomy. They didn't have any history suggesting of mid-layer involvement. However, as a routine, when we evaluated the hearing of these kids, we found some of them had significant hearing loss and many of them had a mid-layer effusion. This condition is often diagnosed or noticed by the mother or the class teacher. You may notice the poor performance, the class teacher may notice that the child is not performing well in the school, and mother may notice that the child is unnecessarily shouting or unnecessarily increasing the volume of the television when the child is watching the TV. Even when others are comfortably hearing, the child is not able to hear. So these are some indirect observations which brings the child to the doctor. Now, what are the causes of this? To begin with, as we know, the ventilation of the mid-layer is only and only by the eustachian tube. It is a completely closed cavity. There is no connections to the external environment except the eustachian tube, which is otherwise a closed tube and opens due to certain actions like swallowing, yawning, and forced Valsalva maneuvers. So these are the actions which open the eustachian tube. Otherwise, eustachian tube is a closed cavity the closed tube by virtue of its anatomical structure, the cartilage which always closes it, and it is by the muscles levator palatine and the tensor palatine, which are attached to the cartilage of the tube. And the causes of eustachian dysfunction may be an obstruction or the dysfunction, and adenoid hypertrophy, one of the common cause of this otitis media with effusion. And as we know that this condition is seen commonly in children, often the preschool children or the early school going children. And the adenoid hyperplasia also is a very common condition in this particular age group. And this adenoid hyperplasia, it causes obstruction to the physical obstruction to the eustachian tube. One also causes edema in the nasopharyngeal end of the eustachian tube. The cause of both the adenoid hyperplasia and the edema of the eustachian tube are the same, either infection or allergy. The chronic rhinitis and rhinosinusitis. How rhinitis causes eustachian tube dysfunction? This is by the chronic postnasal discharge causing irritation and edema of the nasopharyngeal end of the eustachian tube. Chronic tonsillitis, again the same causing nasopharyngitis leading to tubal dysfunction. The cleft palate and the palatal palsy. So here it is not the obstruction but inability of the muscles to open the eustachian tube. The muscles, the opening of the eustachian tube is an active process. The muscles, they have to act to open the nasopharyngeal end of the eustachian tube. Now, if these muscles are not proper, anatomically or physiologically, if they are not proper, then there is a chance that the tube may not function properly. And in cleft palate and the submucous, even in submucosal cleft palate or in palatal palsy, it happens that the tube, the muscles which acting the tube are not functioning as per the requirement. Now, second is the nasopharyngeal mass. The nasopharyngeal mass, one of the nasopharyngeal mass is we already discussed, there is the adenoid hyperplasia. However, in adults, adolescents, and elderly, in adults, example, juvenile nasopharyngeal angiofibroma, in adolescents, in adults and elderly, the nasopharyngeal carcinoma, they are also the common, they also can cause a significant eustachian dysfunction leading to serous otitis media. So, one of the dictum is if a middle-aged person presents with the serous otitis media, then we have to evaluate his or we have to perform a diagnostic nasal endoscopy to examine the nasopharynx, and the presence of the nasopharyngeal mass need to be ruled out. Radiotherapy is one of the cause of tubal dysfunction, again because of the edema in the nasopharynx. Allergy by causing increased secretory activity of the mid-layer mucosa. This can cause collection of fluid in the mid-layer, that is mid-layer effusion or otitis media with effusion. The unresolved otitis media. The acute otitis media, we know the fifth stage is stage of resolution. The fourth stage is stage of resolution. And if it fails to resolve completely the separation that happened because of the institution of treatment, either antibiotic and decongestant anti-inflammatory medication. It started resolving, but after some time, the resolution stops. So at this point, what happens is the fluid in the mid layer, it remains there for quite long time, and that is the cause of serous otitis media or otitis media with effusion. And many times it happens that the virulence of the organism causing acute otitis media is low. Hence, the patient may not present with the classical symptoms of acute otitis media. Hence, the inadequate treatment with the anti-inflammatory drugs leads to a prolonged illness. However, it is not aggressive enough to cause suppuration. And that is how unresolved otitis media may cause serous otitis media or otitis media with effusion. Viral infections like adenovirus and rhinovirus, they also cause increased activity of the mucus glands in the mid layer, leading to mid layer effusion. Now we have classified here in the previous list, we have certain causes which cause gestational dysfunctions and certain causes which can cause increased secretions. Gestational dysfunction, again, it may be obstruction like adenoid hyperplasia, tumors, palatal defects, barotrauma, hyperbaric oxygen therapy, again for certain conditions like sensorineural hearing loss or facial palsy, and edema due to radiation therapy. All this can cause obstruction of the intestinum, and infections like chronic adenoiditis, tonsillitis, and rhinosinusitis, they can cause spread of infection through the intestinal tube into the mid-ear cavity, and allergy can cause increased secretions, and infections like unresolved otitis media and the viral infection, they comes in the category of increased secretions. So this is the etiology of serous otitis media. Coming to the pathology, gestation tube has a function of ventilation as well as the outlet. Whenever there is tubal dysfunction, initially what happens is the absorption of air that is present in the mid-layer cavity. The air in the mid-layer cavity is absorbed by the blood vessels, and this leads to a negative pressure in the mid-layer cavity. This in turn causes secretion of the increased secretion from the mucus glands, and the initial cause causing the eustachian tube dysfunction is the causing increased secretion is the tube dysfunction. So there is increased secretion on one side and there is obstruction to the outflow. So this causes accumulation of secretions of the in the mid-layer cavity. However, as there is no invasion by any one of the bacteria, this remains indolent and this will not lead to a classical acute suppurative otitis media. However, if there is an invasion of the bacteria, so this will turn into acute otitis media. The clinical features and the symptoms and the signs. One of the common, especially an undergraduate, when we ask the question of what is the clinical features of serous otitis media, then they say serous type of discharge is seen. We need to remember that serous otitis media will not cause any type of ear discharge, and even the pain is not a classical feature of a serous otitis media. However, the predominant symptom is the deafness, but the deafness is not always reported by the person having the disease, because it is the small kids which are having the disease, and it is noticed by either the parents or the teachers. And next is the delayed or defective speech. Why is delayed or defective speech? If the deafness is not noticed, for example, a 2 to 3-year-old child has started developing serous otitis media, and that was not noticed by anyone of either the parents or the teachers. Of course, if the kid is going to school, and undiagnosed deafness can lead to delayed or defective speech. Mild earache, of course, it may not be that significant, and occasionally they may also present with the tinnitus and vertigo. When we examine the tympanic membrane, the first thing is the dull or retracted tympanic membrane because of the tubal dysfunction leading to negative medullary pressure. It may look opaque or sometimes blue or amber colored tympanic membrane. So, serous otitis media is one of the differential diagnoses for blue tympanic membrane. Others we have like a hemotympanum or the high jugular bulb or globus. The absence of light reflex, that is the cone of light, because the retracted tympanic membrane causes dispersion of the light, hence the light of the cone of light will be distorted. When we check the mobility of the tympanic membrane, it will have a decreased mobility. The mobility is checked by the Siegel's pneumatic speculum. We can at times see fluid or air bubbles within the medullary cavity, which is seen through the translucent tympanic membrane. So, in this picture, we are seeing the bubbles within the medullary, and that is seen through the translucent tympanic membrane. Next is the hearing test. So, this is most of the times enough for us to clinically diagnose otitis media with effusion. And you have seen that there is no signs of infection like congestion or leach of blood vessels that is typically seen in acute otitis media. And when we come to the hearing test, so first is the clinical test of hearing. And unfortunately, many times the child is a small kid and the results are not very much reliable. However, if the same occurs in an adult, then of course our tuning fork test will give a clue of a conductive hearing loss in the form of Rene's negative and the Weber's lateralized to the affected side, as in any other condition with the acute otitis, the conductive deafness. Now, the next step is the pure tone audiometry. Again, the reliability of the test is low in small children, but in older children and adults, we may find a classical conductive hearing loss with an airborne gap of up to 20 to 40 decibel. It may not be more than this. However, to have a conclusive evidence of otitis media effusion, we need to get an emittance or impedance audiometry. So, this will show a B type of tympanogram, that is the flat type, or occasionally in the early stage it may even see a C type of tympanogram. So, we all know what is B and C type. B is the flat tympanogram because the pressure in the external mid-layer will not change when we alter the pressure in the external auditory canal, because there is a fluid in the mid-layer cavity. Any type of fluid like the mid-layer effusion or hemotympanum can cause a B type of tympanogram. Rarely it can cause a C type because there is negative pressure and the cavity is not completely filled with the fluid. So, in those conditions, we can still get a C type of tympanogram. Now, so with this, we have evidence of having a mid-ear effusion. The presenting symptom, the age group, and the clinical appearance of the tympanic membrane, the added audiometric test will give a diagnosis of serous otitis media. Now, what are the options of treatment? We have medical treatment in the form of decongestants. Now, the decongestant, the intention is to first restore the mid-layer ventilation. As we know, the best way to restore is to restore the function of the eustachian tube whenever possible. And decongestants, either in the form of nasal drops or the systemically taken decongestants, will help in opening of the eustachian tube, and this in turn will help in ventilation of the mid-layer cavity. The antihistaminics will reduce the symptoms of allergy And as allergy is proposed as one of the common cause of otitis media with effusion, the antihistaminic will help in treating otitis media with effusion. Antibiotics, as we have known that if the patient had any history suggestive of acute otitis media, and if we think that this condition which is seen is a residue of the acute suppurative otitis media, then definitely there is an indication to start antibacterial and at appropriate dose and appropriate duration. This is important as the, in the initial period, if the when the patient actually had acute suppurative otitis media and if it is treated half, then that could be one of the cause of having a residual collection in the miliary cavity. Steroids, of course, in the form of topical as well as systemically. Systemic, of course, they not much role, but definitely the topical steroids will help in reducing the edema of the eustachian nasopharyngeal end of the eustachian tube. It can also help by reducing the size of the adenoids in the nasopharynx, in turn restoring the ventilation of the miliary cavity and resolution of the miliary effusion. Now, certain maneuvers like Valsalva. So, Valsalva is one of the maneuvers if the tubal opening is not completely occluded by any mass or adenoid tissue. Then definitely there is a role of Valsalva. It is performed by pinching the nose, closing the mouth and blowing out so that the air passes through the eustachian tube into the miliary cavity. Next is the polymerization. Polymer bag, as we know, it's an olive shaped bag, pear shaped, we can say, a bag with a tube, and the end of the tube passes into the nasal cavity, and after passing, the nose is pinched and patient is asked to swallow, and the meantime we are supposed to press the bulb. This forcefully causes ingress of air into the miliary cavity. However, both the swallowing as well as the pressing the bulb need to be synchronized. Now, when the conservative treatment is not helping, one thing what I would suggest is among the investigations, the nasal endoscope. The nasal endoscopy is important to visualize the nasopharynx, and it is a whenever possible that is a must. However, in small kids, they won't cooperate for diagnostic nasal endoscopy. If we still suspect adenoid hypertrophy is the cause of otitis media with effusion, then we can go for imaging in the form of X-ray of the nasopharynx lateral view, which will show the varying grades of adenoid hypertrophy. However, this may not be always true. There are cases where the lateral X-ray will not show a huge mass. However, when we perform a diagnostic endoscopy, we are seeing a lot of adenoid tissue around the eustachian tube opening. So that is why whenever possible, it is good to have a diagnostic nasal endoscopy rather than only relying on the X-ray of the nasopharynx, which can give either a false positive or a false negative impression. Coming to the surgical treatment. So we know that there is a collection in the miliary cavity and we fail to drain it through its natural exit, that is the eustachian tube. So what we can do? We have to make an opening, and the only wall which we can break is the tympanic membrane, because that is the thinnest wall of the miliary cavity. And where to open? So where to open? Now, we know the tympanic membrane is divided into quadrant by two lines. One line, straight line across or along the handle of malleus, and the second one perpendicular to the first line at the umbo. And a radial incision is placed in the anteroinferior quadrant. Why? To the radial incision. By placing the incision, we are not actually cutting the fibers and we are just splitting the radial fibers. Of course, the middle layer of the fibers, tympanic membrane has a different layers of fibers, radial fibers, circular fibers and parabolic fibers. As the radial is one of the important layer, it forms the important bulk, and by incising radially, we are not actually cutting the fibers, however, we are splitting the radial fibers. Sometimes the fluid is so thick and we fail to drain. As we know that when a bottle is completely filled with the fluid, and that is a thick fluid, and when we make a small leak, we may not be able to drain it completely. That time we can place an extra incision on the diagonally opposite side, that is the posterior superior part, but we need to be careful to incise because we may damage. If we are careless or if we are not careful, then we may damage the includostepital joint. And this incision is sometimes called as a beer can incision. Now, this is a temporary procedure purely. We are evacuating the collected fluid in the midlayer cavity. But is it enough if the disease process is a continuous process, or we are not very much convinced that the tubal function may be immediately restored? So, in those cases, we may have to create a ventilation to the midlayer cavity. So, how? So, we have the option of a grommet or ventilation tube. The grommet is a rescue for many of the children with the eustachian dysfunction, and of course it is very important in child or in children with the cleft, because as I already mentioned about the cleft, the mechanism of collection in cleft is totally different one. In cleft, the secretion, the eustachian tube is not the anatomical obstruction, but it is because of the dysfunction of the muscles. And there are reports that up to 95% of patients with the cleft palate are likely to have a eustachian dysfunction and serous otitis media as a sequel. And in spite of having a very good repair of the cleft palate, 50% of them still continue to have the serous otitis media. So that is really a challenging task, and in those kids, it is always advisable to have a grommet insertion during or subsequently to the cleft palate repair. Now, there are different types of, just to mention a few of the ventilation tube of the grommet. Now, we have the Armstrong tube, which is a mid-term pressure equalization tube with a beveled inner flange angled to the shed and allows easier insertion. The beveled one will lead to will help in easier insertion. We have Donaldson, which is short-term pressure tube that offers good ventilation and dual flange design, and this resists migration. And this is made up of a silicon, and this is more of a inert, and it is elastic also. We have the other tube called bobbin, which is again a mid-term pressure equalization tube that is a good history of providing longer duration of mid-ear ventilations. And there are Shefford and Shahs, which are commonly used in clinical practice, and these both are mid-term pressure equalization tubes, and they get extruded on their own. Again, the duration after which the grommet is extruded is not very specific. It can start after 3 months, but it may even remain for a year in certain cases, even with the mid-term pressure equalization tube. However, when we need a long-term tube, example, a patient with a cleft palate, where a short term is not enough because the tube dysfunction is not going to resolve completely in a short term. So, in those cases, we need to have a long-term pressure equalization tube. It has a shaft and a flanges, and these flanges can be shortened and they are inserted after the myringotomy, and when you release, the flanges will open and the tube will remain for long term. So, this is the advantage of having a T tube in patients with the cleft palate. Why? Because the cleft palate patients will have a prolonged eustachian dysfunction, and in spite of good repair, the chance of having recovered is less. The recovery is less. The other indication for having a long-term tube is the patients of nasopharyngeal malignancies who had undergone radiotherapy leading to cicatrization of the medial end of the eustachian tube or the edema of the eustachian tube causing near permanent dysfunction of the eustachian tube. They are also the candidates for having a long-term T tubes. Now coming to the primary treatment of the primary pathology. By medical treatment, we try to open up the eustachian tube. Also, to certain extent, we try to control the primary cause. However, in conditions where there is significant obstruction or the dysfunction of the eustachian tube in the nasopharynx, we have to treat the primary cause either simultaneously or subsequently. It is always good to treat both together because most of these are kids and the procedure is done under general anesthesia, and a same sitting, both the things can be clear. As I already mentioned, the adenoidectomy. So initially, since I already told that I was involved in two of such studies. So one was the initial study where we started is we performed audiometry in kids who are admitted for adenoidectomy. And the next step what we did is that we evaluated all patients with adenoid hypertrophy. And in both the groups, the incidence of the presence of serous otitis media was quite significant. And now that is why it is like when we do adenoidectomy, it is always better to look for the presence of serous otitis media. And whenever there is a serous otitis media, always look for nasopharynx and get rid of this enlarged adenoids. Now, the adenoidectomy can be done. Since the topic is not adenoidectomy, I am not going to elaborately discuss these things. However, just for the sake of completion, I am mentioning the different methods by which we can do a adenoidectomy. And one is using a curette. Of course, curette is a blind procedure, but to show how the curette is used, I am just showing the images with the help of an endoscope. This is the initial adenoid mass, and we have passed the adenoid curette, and the adenoid is curetted, and we have got a significant nasopharyngeal airway even with the adenoidectomy curette. Nowadays, most of these procedures are performed under direct vision, and endoscopic adenoidectomy either with the microdebrider or with the cobbleters. So, microdebrider has the advantage of taking out the adenoid bit by bit, and since it is done under direct visualization, we are able to completely remove the adenoid mass. This is the microdebrider and this is the blade, and this is how the adenoid mass is taken with bit by bit with the help of microdebrider. The latest one most of us are using now is the cobbleter assisted adenoidectomy. So cobbleter, it simply evaporates the adenoid tissue. There won't be anything left when we go ablate using a cobbleter. So this again, but the advantage of cobbleter or or the microdebrider is the less bleeding. We can see many times a bloodless field after cobbleter assisted adenoidectomy. So these are the different techniques of tackling the enlarged adenoids. So apart from this, as I already mentioned, adenoid is not the only cause. We have certain other causes like juvenile nasopharyngeal fibroma, the nasopharyngeal malignancy, and so on. So those need to be managed as per the disease, and if the child is having allergic rhinitis or chronic rhinosinusitis, that do need to be managed with the appropriate measures. either in the form of a steroid nasal spray or the appropriate antibacterial therapy. Now, what happens if the serous otitis media or otitis media with effusion or the mid-ear effusion is not treated? If it remains for long time, there is a chance that the tympanic membrane can bear the brunt and this becomes thinned out, and it becomes atrophic. It becomes a thin and atrophic tympanic membrane. The mid-layer ventilation is hampered for long time, hence there is atelectasis. The mid-layer pressure gets negative and the air is completely absorbed and the tympanic membrane starts retracting to a certain extent that it may get adhered to the medial wall of the mid-layer, leading to adhesive otitis media. It can even lead to ossicular necrosis because of the presence of fluid in the mid-layer for longer time. Next common is the meringosclerosis and tympanosclerosis. The tympanosclerosis can affect any part of the mid-layer cavity, and the most commonly it is seen on the tympanic membrane, and this is one of the important sequelae of serous or otitis media with effusion. Next common is the retraction pocket in polysteatoma. Here, the primary mechanism, the primary process that is happening here is the eustachian tube dysfunction. The tube dysfunction on one side causing serous otitis media with effusion, and on the other side it is causing negative pressure, and this negative pressure will lead to a retraction pocket, and subsequently the retraction pocket may deepen and it will lead to a formation of cholesteatoma. As we know, the Whitmark's theory of cholesteatoma formation. Otherwise, there is a chance of this serous otitis media or the mid-layer effusion leading to the formation of cholesterol granuloma. The granuloma may remain for certain period, and this may cause us recurrent infection and sometimes a significant conductive hearing loss. So these are the sequelae of this otitis media with effusion. I cannot call it as a complication because the disease process is still limited to the tympanic mid-layer cleft. So that's about from my side about otitis media with effusion, and if there are any questions, I am happy to take here. Thank you, and once again thank the NBE for giving me an opportunity, and I appreciate the participation of the trainees in this session. If there are any questions, I can answer in the chat box or the Q&A.
Dear trainees, you may type your questions, comments in the chat box. Dr. Vadisha, I hope you are
Yes,
able
sir.
to see the chat box.
Yeah, I am able to see the chat box. I didn't have any. Yeah, 1 second. Sorry. Yes, one question.
And dear trainees,
Importance
you
of,
may
yeah,
also use raise hand option so that I can give you the access to
correct.
unmute
Yeah,
yourself.
I got the chat box. Importance of radial incision. Yeah, basically the radial incision is here. Sorry, yeah, there are two questions of similar type. One is the importance of radial incision, and other is the radial incision and steroid drops are required. Okay, fine. So, to take the first question, radial is, I mentioned that the majority of the fibers are radial, and when we place the radial incision, uh, it splits the fibers and we can negotiate a grommet into the through the two fibers that are split apart, and this helps in healing when the grommet is extruded or it is taken out. And antibacterial steroid drops are not advisable in serous otitis media. They are not used, and we never use it. And even the literature says there is no role of antibiotic and no role of antibiotic or steroid ear drops for otitis media with the effusion. However, we can always go for a steroid nasal spray or oral steroids in certain cases which are resistant to conventional treatment. I hope I have answered this question. I think I have answered both Dr. Urvish Patel and Dr. Yuvraj's questions. I think I'll stop sharing my slides and I'll probably yes.
Dr. Vadisha, please unmute yourself. You're muted.
Yeah, Dr. Yuvraj has a question that steroid nasal spray in OME. Yeah, as such, steroid nasal spray do not directly affect the otitis media with effusion. However, it affects the nasopharyngeal end of the eustachian tube, and it reduces the edema in the nasopharyngeal end of the eustachian tube, and it helps in ventilation of the eustachian tube. Also, as allergy is one of the important etiological factor for otitis media with effusion, this reduces the allergy, reduces the edema due to the allergy, and hence restores the ventilation of the medullary cavity. Dr. Akanksha has a question. I expected this question and I thought I had a power failure here. I think I was answering the question of Dr. Akanksha. How much time?
Yes, sir.
Good evening, Dr. Akanksha. What is the time when we should decide about the meningotomy? Definitely, it is a tough job, and there is no uniform rule when we should go for the meningotomy. If the patient is having a significant hearing loss, and I believe that is the day to, and if you are having a definite evidence of tubal dysfunction due to either adenoid hypertrophy, then we can go immediately for the surgical treatment. Otherwise, it can be titrated depending on the response of the child, both subjective and objective, as evidenced by the audiometry. So, otherwise, there is no clear-cut black and white rule for this.
Sir, you have
Yeah.
again mute.
Yes, sorry. Actually, I was getting the call from our dean, that is why I muted immediately. Mechanism of causing SOM cleft palate. Yes, Dr. Urvish, here some part I mentioned that normally the eustachian tube is a closed one and the tube is opened with the help of muscles. The muscles are not dysfunctional in cleft palate because the attachment of the muscles are not straight. There has a situations the tubal opening is either incomplete or sometimes it may not open at all. So that is the cause of SOM in cleft palate and even in palatal palsy. And Dr. Yuvraj is saying that I think I have answered Dr. Urvish questions. Eustachian tube nasopharyngeal is maintained by torus tuberous cartilage muscle. Yes, fine. Gerlach tonsils, yes, definitely. There are, well, I don't have a first-hand experience of this. However, the tubal tonsils are also, theoretically, are also one of the important cause of otitis media with effusion. However, isolated involvement of tubal or isolated enlargement of Gerlach tonsils are not common. So generally, it is a diffuse enlargement diffuse enlargement uh, of the adenoids also. Yes, Valsalva is an important. Yes, Doctor, I am answering Dr. Yuvraj question again. So, role of Valsalva in otitis media with effusion. So, here one point to be noted is if the obstruction is mechanical and if the patient is having a huge mass in the nasopharynx causing obstruction, then I would say the role of Valsalva is meager. However, if the condition is something like allergy or unresolved acute otitis media or a barotrauma, where there is still a role of Valsalva because the nasopharyngeal end is not occluded by mechanically and the Valsalva can still push some air into the tympanic cavity. So, Valsalva definitely has a role. And of course, also to mention the incidence of otitis media with effusion even in adults, it's common after an episode of acute otitis media. So it is not that uncommon as we think. Even in our clinical practice, we often come across people with the serous otitis, especially when they travel, when they have a acute rhinitis. Yes, definitely the steroid nasal spray and Valsalva is an option as both. I mean, the steroid also will help in regress or increasing the edema. I mean, reducing the edema of the eustachian tube and increasing the ventilation of the mid-layer, and audiometry is normal. With intact TM and clinically, audiometry is normal. So I don't think there is any audiometry when we say there is a chance that in spite of having a beat tympanogram, patient may not have hearing loss. So in those conditions, we can advise this because there is a proven the presence of fluid in the mid-layer is proven, but it is not enough to cause a deafness. So in those conditions, I would still say yes, we can go for the steroid nasal spray plus Valsalva. But otherwise, if the tympanometry is absolutely normal, there is no role of Valsalva as such because the ear is apparently or ear is otherwise normal in such conditions. Yeah, I think the first part of the question I missed, Dr. Yuvraj. Incidence of like symptoms in winter and seasonal. Yes, this is similar to what I was explaining now. Those getting repeated otitis media with effusion during travel. Probably I can compare the situation with that. In those conditions, yes, we can give a short course of the either a steroid nasal spray or decongestant, and we specifically advise those patients to take care of their ear when they are having their disease in the nose.
Any more questions, trainees? So if there are none, thank you very much, Professor Dr. Vadisha Bhat, for the presentation, and thank you very much, trainees and faculty members, for joining.
Thank you, sir. And I thank the NBE for giving me an opportunity and all the participants to be here with us.